Well, there really are two important reasons. The first one is, let's define what customized welfare expenditures means. It means essentially case coordination. And if you paid attention to what Bill said, he gave you a lot of different aspects of welfare. Mental illness, financial aid, homelessness, etc. Now, unfortunately, in our welfare system, these are different silos that are not speaking to each other. And people remain in one of those silos when they may need to go over to another silo. And that's where the case coordination would come in, meaning a separate collection of services for each client. Because they're not getting that, they remain in the system, and that just keeps the cost going up and up. Now, the second reason, and this is the paradox, is despite the cost going up and up, many of these services are not being utilized. And it's because people don't know about them. And then that's, again, where the case coordination becomes very critical. It helps people solve the red tape problem and get connected and hold their hands. Unless you're well educated, these government bureaucracies can seem like a Kafkaesque castle, and you don't know how to open the door. And again, the case coordination will do that. So it will reduce expenditures by getting people out of the system, and will reduce expenditures by seeing to it that money is not wasted.
Well, the first response to that is that the major manifestations of it, the first thing you see when you look at it is the failure of the country to satisfactorily deal with the pandemic over COVID-19. And the other one is the opioid crisis, which has sort of come upon the healthcare system in the United States and become, death from drug overdoses has become a major cause of death. And we have significant parts of the population addicted to drugs in some parts of the country. But underlying these failures, these problems, are really fundamental problems in the system. Is one, it costs way too much. Recently we've been spending 17% of our GDP on healthcare, and compared to countries that you would think of in the Organization for Economic Cooperation and Development, compared to countries that you would think would be comparable to the United States, we're spending a third to a half more money than they are. And that might be worthwhile if we were getting good results out of it, but we're not. As Americans aren't as healthy as people in these other countries, and they don't live as long. The basic indicators of this are life expectancy and infant mortality. And life expectancy in the United States, we rank 32 out of 38 countries in the OECD. And for infant mortality, it's also 32. So we're ranking very low with countries that you might think where we should be comparable. Another thing to look at there is life expectancy at age 65. And this is interesting because in our system, we do have Medicare, which covers the vast proportion of the population over age 65. And there we rank 17th for males and 30th for females. That's out of 38 different countries. So we don't even rank well there, although it's better than on life expectancy and infant mortality. So the expenditures, the healthcare system is very expensive. And that's important in its own right, is that it's costing us all this money, but it's also that the money we spend on healthcare we don't get to spend on other things. The argument is that it's very difficult actually to separate the two. Is the underlying causes of health. First, you have to distinguish between health and health care. healthcare is supposed to restore your health after it's compromised. But hopefully it wouldn't be compromised in the first place. And that comes from partly genetics, of course, but also from the social circumstances. And so we know that there's a relationship between health and income and education and neighborhood and lifestyle and individual choices about lifestyles. And all of these things contribute to creating and maintaining health. And healthcare is another important part of it. So, but these other parts of it are what we think of as social welfare. Now, at the intersection of these two, you get down to biological problems, and there's a very interesting book called Descartes' Error, in which the author argues that Descartes separated mind and body because at the time of his life, he was in conflict with the Catholic Church. And in order to resolve that conflict, he said, look, you deal with the soul. I'm concerned about the body, and they're different. And Descartes' error argues that this isn't true, that body and soul are united together in the brain. And in order to reason rationally, you have to have a working emotional system. So there is no separation between welfare and health. The World Health Organization has a very general definition of health that includes every aspect of physical well-being and also includes mental health and social well-being. So there is no separation between welfare and health. They go together and they support each other. And they support each other in the ways that say you lose your job, you lose your income. And then you get depressed because you haven't got work. You get hungry because you can't afford to buy food, or you get homeless because you can't afford to pay rent. So all of these problems that the welfare system is designed to deal with, homelessness, shortage of food, and depression and anxiety, these problems are health problems, but they're also welfare problems. So there's really no separation between the two.
I'd like to add a little bit here too. I want to point out in particular are the deaths of despair. And I want to make a comment about the conservative economists who are trying to explain deaths of despair away by saying, well, it's because fentanyl is being laced with chemicals coming from China. But that denies the fact that people are buying more and more fentanyl drugs. And that's the real issue here. That's showing that despair is rising. And the other thing, the reason why despair is rising is particularly rising among the young. And that's because they have rising levels of anxiety and depression. They're concerned about the future. And that's not only a welfare problem, that's an education problem.
And it's also a social control problem. Because in a sense, these drugs create their own demand. You know, we didn't have an opioid crisis until there was OxyContin. The introduction of OxyContin created the problem. It was a useful drug. It treats pain and some other problems, but it creates addiction. And it's interesting in the context of tariffs. Is we want to stop trading with other countries. Well, we have a very big trading in health. Is we're exporting scientific knowledge at the same time that we're deciding we're going to cut scientific research and choke off the source of that we're exporting. And by doing this, we're attracting talent for people that want to come here and get trained. Education is one of our most important exports. And the people that come here to get trained, many of them stay. so that our healthcare system is staffed in very substantial amounts, different at different levels perhaps, but in substantial amounts everywhere, by people that were born somewhere else and migrated here. We have foreign doctors and we have foreign nurses. The Philippines, for instance, is one of the most important sources of nurses in this country. And if you choke that off, where are we going to get nurses? We're not training our own people. And that's, of course, one of the solutions to the problems that we've got, is if we could train our own people. Jobs like nurses pay well. So one of the problems of poverty in America is to train the people as nurses and let them go to work. They need to be customized because the system itself has problems. The first problem of the healthcare system that's driving up the cost is that it's overly specialized. We rely on specialists for healthcare rather than primary care. So there is an insufficient number of primary care physicians, and there are too many specialists. When you have the specialists, you go to the specialists and they deal with their specialty. They don't deal with the rest of you. Whereas the primary care physician is responsible for dealing with you holistically and as a person, to dealing with all of your problems and seeing how they relate to each other, and to try and coordinate the care. And in some cases, people have gone on, doctors and studies have gone into people's homes and asked them, what drugs are you taking? And you find out they're taking 15 different drugs, and the drugs are incompatible with each other. Some of them they used to need and they don't need anymore, and then others of them they should be getting and aren't getting, and some of them are incompatible with each other and at war with each other and canceling each other out, or creating ill effects of their own. And then people go into the doctors to compare about the ill effects, and they get some more drugs to counter the ill effects. It all drives up the costs of drugs, it drives up the cost of care, and the result, of course, is poorer outcomes for the patients. And so we need more primary care physicians that are coordinating these cares. Now, there are other aspects of the system that are failing too at other levels. There's a very poor geographic distribution of care. So there are parts of our country where if you're a woman having a baby, you have no access to obstetricians and gynecologists. Nobody there to deliver the baby. And this again is related to matching levels of skill of the care providers, because we don't have a good system of midwives, for instance, to help people in remote areas or in poor areas, which is another aspect of the distribution of healthcare. Is under a capitalist system, healthcare goes to the people that can pay for it. And that means that poor people who have trouble paying for things don't have access to care. The doctors are distributed. There are more doctors in Massachusetts per capita than anywhere else in the country, because the medical schools are located there, so many of them, and they have a good system of education and people that appreciate and know how to use healthcare, and they have a system that's very intensive in healthcare in Massachusetts.
You say you can, you estimate up to $2 trillion a year to save?
Well, that's based on comparisons with other countries. I mentioned that the U.S. was spending 17% of our gross national product. The next most expensive, the next country that contributes the most of its resources to healthcare is Canada, and they're paying only 13%. So it's 70% of what we're paying. So that's 3% of our GDP that should be available or could be available if we had a more efficient system. Of course, if we had one that was efficient as the English system, and they are, by the way, getting better results in terms of health outcomes than we are, but they're only spending half as much on their healthcare system as we do.
I wanted to add something. Studies show that as the number of specialists in a particular area increases, the number of procedures increases as well as the cost of each individual procedure. In other words, rather than as the economist market, competition drives down prices. In this case, competition drives up prices, and that's another factor that's making our system very expensive, and the misallocation of not having everyone, of not being carefully allocated across the regions is driving up costs.
Well, this is another very fundamental failure of our healthcare system. Is in the United States, we have been committed to market economies. And the fundamental problem here is that healthcare is not a commodity. Is markets don't work for healthcare. And this has been documented over and over again. But we fail to understand this and continue to think that the way we're going to drive down the cost of healthcare is to introduce competition. Now, you can get competition between hospitals, but the way in which hospitals compete is with the level of service they provide. So they provide higher and higher services, which cost more and more money. So competition among hospitals doesn't control costs, it drives them up.
Again, we argue in our book that it's systemic coordinated interorganizational networks which would combine different parts of the healthcare system along with representatives of the doctors and nurses and other professional groups that are involved in healthcare would together create an efficient system. Now, an example of how that could occur is provided in our book, particularly in a diagram I.2, which takes up the case of child poverty, which is just the welfare side, and shows how, with a coordinating mechanism, a number of different services are brought to bear to help a particular child who's poor. And the same would be here. It would involve health care, but also access to welfare support insofar as it's needed.
Well, they're related.
Yeah.
Okay, they're related. As we know that health is related to education. People with high levels of education have better health than people with low levels of education. As income inequality is increased, the inequality in mortality has increased. And so if you could educate people better, you could reduce the inequality in health, presumably. Now, there's a whole lot more to it than just that, but there are lots of other factors. The areas of concentrated poverty, living in an area of concentrated poverty, in one study that I did, is just as bad for you as regular cigarette smoking. And so if you could reduce the segregation by race and by income, segregation by race has declined marginally in this country over the last few decades, but segregation by income has increased dramatically. And these, if you want to consider them that, these declines in the quality of society have led to increases in inequality in health. And mortality is just an indicator of that, is various other kinds of indicators and other measures of health for the working age population have also increased in inequality.
One of the really interesting studies done in England is on their national healthcare system, which is a universal healthcare system, and they discovered that it was not driving down mortality rates as fast among the working class. So they did a detailed, in-depth study, and they discovered the working class doesn't know when a disease is critical, and therefore they should see a doctor. And they wait until too long, and then the disease is gotten more difficult to cure and much more expensive. And that is a problem everywhere. That's why Bill puts an emphasis on education. So you need, again, case coordination as a way of dealing it. And interestingly enough, another thing that drives up the cost, there have been studies done of this, and it's people don't remember to take their medicines. This seems stupid, and I don't mean that critically of the people involved, but they don't. And to the credit of Prince George's County, they now go around and check on their patients to be sure they're taking their medications when they're supposed to.
There was a particular problem with this with tuberculosis, because the medical regimen for tuberculosis, I think it may have changed in the last few years, but in the past, it was a very difficult routine. Is you had to take a pill every day for like 6 months. And it was a very big pill and difficult to take. And so they developed a system of therapy called directly observed therapy. And the downside of not taking your pills, of course, is that if you don't take your pills, what you are doing is you're cultivating drug-resistant tuberculosis. Now, this is a very serious problem, because if you go back 120 years, tuberculosis was a leading cause of death in this country. We're not talking about, something like the common cold. This is a very serious disease, and it's a very difficult death. It's you're choking to death, basically. And so, and the other thing is, of course, is we have very few drugs that are effective against tuberculosis. It's not like any antibiotic is going to do it. So drug-resistant tuberculosis is a very serious threat to our welfare. So they developed directly observed therapy, where you send a worker every day to the patient's house and watch them take their pill. And doing that, they were able to reduce the level of tuberculosis to the level where in the late 80s, they decided we don't need to do this anymore, and they stopped funding tuberculosis programs. And then the HIV epidemic came around. HIV reduces your resistance to infection, and the tuberculosis rates started going up again. And they had to rush and re-implement the tuberculosis control programs.
Yes, I mean, let us start with the areas that are perhaps most in need, the poor and the rural areas. We have a system that was started, I should say, under President Johnson, called community health centers. And there is an organization of them. Most of these are located, and it's required by law, in either rural areas or in poor areas. And they can become the starting point of creating a SEON in these areas. What they would then do is become the coordinating organization that would pull in the different organizations that people would want to include in this. And this includes the professionals, the healthcare providers, doctors and nurses, and would also, and dentists and so on, and particularly mental health practitioners. And it would also include the various local, county, and state services in healthcare and in welfare, so that they're all contributing. And this would also provide additional funds, as well as the funds that these medical centers are getting. And the idea would be to start here with these already and demonstrate the effectiveness of it, and then it could become a national program. And that's, I think, the best way of gradually moving towards a universal healthcare system where we eliminate the private sector. But it's done starting in the rural and the poor areas. We think that by starting with these community medical centers, it'll be relatively easy, but it's very important to recognize that the private hospitals and the insurers will oppose this. And the only hope is that as the system grows, they will lose clients. And as they lose clients, they will be forced to join it and change their policies.
In the welfare area, I think it will be easier. Right now, homelessness, for instance, is to be addressed by the Department of Housing. Education issues are addressed by the Education Department. Unemployment and underemployment are addressed by the Labor Department. So you have all these different departments, and they're not coordinating and they're not working together, and they each have their own set of rules. So from the point of view of somebody who is unemployed and needs to get retrained and get into a new job, has to deal with all these different departments, and each department has its own set of rules. And these people aren't bureaucrats. They don't understand these rules. They don't understand the bureaucracy, and they have to fill out all these complicated forms, and many of them aren't good at filling out forms. And so they just give up. And a Scion could help with this by coordinating between these different departments and hopefully advocating for integrated programs and creating more flexible systems of addressing these programs.
This would have to be done at the state level, I'm guessing, because the federal government in place at this moment is actively trying to dismantle everything as it relates to education and health.
Well, in general, we've always felt that the Scions for health and welfare should start at the local level, that's where you're likely to get support from both the elites and the workers, because different interests are being tapped here. And
and it needs to be customized for local areas, customized to the needs of local areas. You're talking about individual people's needs and individual communities' needs, and they're different in different areas. The rural communities have different interests and the economies are different. The need for job training and jobs is different. The educational systems are different. The occupations that people hold are different. So each different community has its own resources and its own needs. And the point here is that the federal government or even the state government can't necessarily address these because they don't have the knowledge and expertise. And the point is that in a Scion, you get the community, people from the community together. And working together, this builds community leadership. And it strengthens community. It builds connections among people in the local areas so that you're building what sociologists call social capital. And the result here is that it brings people together to work together to solve their problems rather than saying, oh, the government's going to do that. Well, the point is the government isn't going to do it. And they're not market problems. It's not a question that a capitalist is going to come along and invest in it and make money in it. It's a question of basically a community and how we take care of each other. No, I think that's the punchline right there. The problems of health and welfare are community problems. It's about how we take care of each other. And it's about bringing people together to say, let's solve our problems and take care of each other.